welcome for the next panel, which is called Globalisation, an ever-present debate in modern society. I already introduced myself. My name is Maximilian Ossana. I'm a student of these venerable institutions. I'm a first-year ETIA student, so Environmental Technology and International Affairs. And I have a background in medical informatics, which is why I will be moderating this debate on public health. So the session is called Aware and Well, a focus on public health. And we will be discussing the impact of globalization on societies, and that the area of public health depends on the successful interactions of countries, which is why we have that talk at the Diplomatic Academy of Vienna, of course. All right, then. For the schedule, I will just introduce the speakers to you, and then we'll let them present their topics. I try to be a little more engaging because one speaker is missing, so I will try to improvise there a little bit. Then we get, of course, the Q&A session where I can all ask questions, and that's basically it. All right, before we start, the one speaker who is missing is Laura Maas. She would have been the doctoral researcher of Leibniz Science Campus of Digital Public Health in Bremen. And she's also a member of the steering committee at the European Public Health Association. So that would have been an interesting speaker. But unfortunately, she caught COVID yesterday and is thus not able to attend today. However, COVID brings me to the introduction of my next speaker, Professor Jeffrey Lazarus. He's head of Health Systems Research Group and the co-director of the Viral and Bacterial Infections Program at the Barcelona Institute of Global Health. He's also an associate professor at the University of Barcelona and a full professor of global health at the CUNY Graduate School of Public Health and Health Policy. He has worked as an infectious disease control expert at the WHO Regional Office for Europe for more than a decade, and he studied at the Georgetown School of Foreign Service. And why is he here today? Because he's going to present to us the global COVID-19 consensus statement he authored with more than 300 participants, if you could call them like that, to analyze the outcome, the political outcome of the COVID-19 pandemic. And with that, I will give you the word to introduce yourself as well, if I missed something. Or
that's fine, thank you.
Perfect, great. And then the second of our speakers will be Miss Kristina Curtis. She is a consultant, researcher, and lecturer and trainer in behavioral science. She's got a lot of expertise in using multidisciplinary approaches to developing digital behavioral change interventions for improving health and well-being. She has worked in a couple of projects about childhood weight management and self-management of chronic conditions. She's currently running a behavioral science research consultancy for governmental departments, technology, startups, and pharmaceutical companies. And she's also an honorary lecturer and associate at the University College's London Centre for Behavioral Change. And she will be talking about the development of health and communication and other project channels for changing health behaviors. All right. Now with that, I declare the stage open and give the word to you, Jeff.
Great, thank you very much, and thank you for the introduction. Great, so my slides are there. As Maximilian said in his introduction of me, I have a background in political science. I went to the Georgetown School of Foreign Service. I then moved into health, working at the World Health Organization and the Global Fund to fight AIDS, tuberculosis, and malaria. And that sort of all coalesced later around health policy with a particular focus on health systems and infectious diseases. So I was working in HIV, I was working in viral hepatitis. Everything was planned, in 2019 for our 2020 work plan. The pandemic hit, and we quickly pivoted. Our team at the Barcelona Institute for Global Health of about 15 people, but also our entire institute of over 500 researchers and other staff. So what did we do? We started thinking, well, what's been working in previous epidemics and pandemics, including H1N1 when I was at WHO, and what can we apply to the current pandemic, and how quickly can we do it? If we're really quick and we stop the pandemic, that would be great, we won't really get any credit because no one would have ever really known that there was a pandemic about to happen. So when we were talking about this, the first weeks of January, when the first news of human-to-human transmission was coming out, we said we have to move very quickly. So, as a political scientist, I said, a few months later, when we saw the pandemic control measures weren't really working, I said, we need to understand how we're going to be able to engage the population, how we get them on board, how do we get them to take this seriously, and how do we get politicians to take this seriously. I was in Spain, so that's extremely challenging to get the politicians to take it seriously, very different than the situation in Austria, and very different than the situation in Denmark, where I quickly went, and I'll explain why in a moment. So in Spain, they decided to call on the population to come out 3 years ago this week, on the 8th of March, for International Women's Day, something we all support, but maybe it doesn't make good sense to have a large crowd gather right when a pandemic is about to be announced. So I think this is an important forum to discuss this, because I typically go to health conferences, infectious disease conferences, and actually our job is largely done. I mean, we have an effective vaccine. It'd be nice if it were longer lasting, but we have a vaccine that's working pretty well, particularly against severe symptoms, hospitalization, and mortality. We have medicines that are working pretty well, and we have general prevention measures that have been around for over a century, even centuries. We have face masks, and now we have very high quality face masks, and we know of the power of ventilation. It's nice to see the door open in the back. We know that the movement of air helps us. Now, why didn't we all apply all these, and why didn't we do it quickly? That's where the political science comes in. That's where we need to understand the economics of the pandemic. Why doesn't the population follow the control measures? That's where we also need to understand the sociological aspects. So 2 summers ago, if we fast forward, we're in the middle of the pandemic, and we're incredibly frustrated. We've done a survey that says most people in the world are willing to get vaccinated if there's an effective vaccine. The vaccine rollout happens very slow in Spain, very quickly in Denmark. We know the mandates you had in Austria and the situation around the world. On the bottom right, you can see the cover of Nature Medicine just this month, where we've now done the 3rd round of the same vaccine hesitancy study. And actually, year on year, we see a big increase in the number of people who are willing to get vaccinated against COVID-19. So in spite of all the noise and opposition to the vaccine that we hear about, the majority of the world's population wants to get vaccinated, is willing to get vaccinated, is vaccinated, and each year in our survey we've shown that it's actually increasing. Still 20% are hesitant, but it's gone up from 70% willing to get vaccinated to 80%. So a year and a half ago in the summer, I was on holiday, I took a break, I was in New Mexico, and I was thinking it'd be nice if I could put all of the recommendations about what needs to be done to end COVID-19 as a public health threat. So borrowing the same language used in the WHO Global Health Sector Strategy on viral hepatitis. So it's not to eliminate it completely, it's to end it as a public health threat, or eliminate it as a public health threat. So I made a long list with my team of all the recommendations, over 111 pages of recommendations, and I realized this is going to be very challenging for politicians. I mean, one of the things I learned 30 years ago at Georgetown was, we wanted to make these one-page summaries, hand it to the politician and say, this is what you need to say and this is what you need to do. So I started trying to boil it down, to one page, and realized as a public health expert, I was completely inadequate to be able to do that for all aspects of what needs to be done. So let me see if I can advance. So you see about 40 names here, and at the end, the COVID-19 consensus panel. So we're 386 panelists. I started by asking the next person on the list and the next person, Christopher Kopka, Salim, Carlos, and others, wherever I had a doubt about treatment, or about the virology, about ventilation, I just called or wrote to the leading experts I could find in the world and asked them the questions, invited them to co-author. I was hoping at 10 or 20 co-authors we could knock it off, but when we hit 40, we realized we had something going. Maybe we could actually try and get representatives from the entire world. In the absence of WHO or any other multilateral or large organization or large NGO doing their job, which should be to bring the world together and get consensus, evidence-based consensus on what to do, we started doing it, right? Just bootstrapping. No funding, just a bunch of technical experts trying to help policymakers take rational decisions. So I contacted Nature and I said, you're a multidisciplinary journal with incredible reach. We have this idea. What do you think? And they said, well, we've never published a Delphi consensus as original research. We've seen what you've been doing, but we want to see more. And we want more gender and more geographic equity. We want to make sure low and middle income countries, but particularly low income countries, are well represented. So that's where we started reaching out from the 40 co-authors to more, 364 co-authors, a panel of 386. What happened to those other 20 plus people who were involved? They were actually high-level government officials who got permission to be a part of the panel, but weren't allowed to co-author because of their positions. Advisors in the European Commission, advisors in Public Health England, in the CDC and other places, including WHO. Some were allowed to co-author, some weren't. But we thought that's fine. They were acknowledged, and it was important to have their voice as well. So we brought together, it was hard to find people from some countries, actually, who knew enough about COVID that they would be involved, but we had most large countries in the entire world represented. So 386 members, and what we did was we chose the Delphi methodology. You can see it a little bit here. I'll explain it very, very briefly, because we wanted to try and reach consensus, but not just, consensus at any cost, consensus on statements and recommendations that really said something. And using the Delphi method, it allows us also to present the amount of disagreement. And one of the challenges of this pandemic has been listening to those who disagree. Those who don't want to get vaccinated, they have a right not to get vaccinated, but they don't have a right to infect others. So how do we get that? How do we get that right, in the laws and in the mandates and so on? So we had this core group of 4 chairs. So we had the former minister of Rwanda, the dean of the CUNY Graduate School of Public Health and Health Policy, where I'm now working. We had Adiba Kamarulzaman, the former head of the International AIDS Society, a medical doctor in Malaysia. We built out the core group, as I explained. We expanded that to a large group of panelists. We used Qualtrics, so we had professional experts methodologists working with us on the software, and we started making a list of statements. And the journal was saying, we don't really care about the statements, we want the recommendations. Like, what are we gonna do? Where's the action? I said, we need the statements because not everyone agrees that this is, airborne transmission, that it's floating with aerosols. People don't understand a lot of the basics of COVID-19, and I want to make sure at least all the experts agree. And if you look in the article, you'll see that not all of the experts agree. We even had a few people writing to us saying it is not airborne, that's never been proven. We had articles in the BMJ and Lancet saying it is proven, so you can imagine the discussions. Some people wanted to pull out, and I said, don't pull out. The point of this exercise is for us to work together to find a solution, and if you want to argue your opposition, we'll include that in the discussion, and if you don't agree at the end, then you can pull out. All of them stayed. But it was a very unique process. It wasn't 10 or 15 experts putting forward their recommendations. It was different than the Lancet Commission that I was also a part of, where we were a group of 28 experts who came up with 11 recommendations over 2 years of discussions. This tried to present the percentage of disagreement and the why of the disagreement on over 40 statements, over 50 recommendations. We would vote, we'd see the comments, we'd revise. I can't even read it from here, but I know the numbers more or less. Over 1,000 comments per round. In the end, over 5,000 comments. A lot of feedback, a lot of repetition as well, but we had to go through every single comment, resolve contradictory comments. We engaged the Wilton Park think tank. Many of you might know the Chatham House think tank in the UK. Wilton Park is similar, back from 1946 when they were working with rebuilding Europe after World War II. They moved into health policy, and they chaired a meeting for us where we could talk about the findings and try and reach consensus as a group. Normally we would meet, we did it online, and finally we were able to publish the results. So I said, at Georgetown, the goal was always to get everything onto one page. We didn't have computers when I studied, really. So now, of course, we could just reduce the font, fit everything on one page, but that's not so helpful. So what I'm just going to present here is that we divided the findings into 6 main domains. There's, of course, some overlap. Treatment and prevention are a part of health systems. Pandemic inequities also links to all of those aspects, vaccination and so on. But these are where the recommendations, we grouped them by what they primarily addressed, so that we could see that to address the pandemic, to end COVID-19 as a public health threat, these were the 6 main areas that needed to be addressed. In the third round of the survey, we had a ranking exercise, and these were the top 10 of those 50-plus recommendations. And if you look on the left in bold, you'll see it wasn't just about health systems. So for me, banging on about health systems to health experts at conferences, that's not enough. That's one piece of the puzzle. It's about communication. It's about prevention. It's about pandemic inequities. At the time, vaccines were being held back from low-income countries, so inequities was one of the big discussions. Later, it was treatment, not being made accessible to low-income countries, other tools and technologies they needed. So you can see here the top 10, and that's been very helpful to share with the policymakers to say, if you really want to end COVID-19 as a public health threat, this is what you need to do. And if I go back one, you can see on the right that obviously these were the ones with the highest level of consensus, so the disagreement on the right is really around 1%, 2 or 3 or 4 or 5 people disagreeing. As you go down and you hit, recommendation 40, 50, 55, you start to see more disagreement. We won't have time in this short presentation to go through those. The number 1 ranked recommendation, it may sound a little cliche, but it was a whole of society approach. It means this is not just a health issue. We need other disciplines, business, civil society, the military, faith-based organizations, the media, psychology, mathematical modeling, and so on. We need to expand the collaboration. So I mentioned, I was in Spain. I saw how the government was responding with this really draconian lockdown. I pivoted, moved back to Denmark, where I used to live, where people were following what the government was saying. There was a lot of trust in the government. There was very low levels of trust in the Spanish authorities. And when the Danish government came out every week in their press release, it was the Prime Minister, flanked by the Minister of Education, the Minister of Justice, the Minister of Interior, the Chief Epidemiologist. Each one would explain, this is why schools are closed, and this is what we're going to do. This is why the borders are closed, and this is what we're going to do. In other countries, I'm not sure how it was in Austria, sometimes it was just an epidemiologist telling us the numbers going up, the numbers going down, but people weren't engaging with the population, speaking their language. Everyone in the country stopped whatever they were doing. They had incredible ratings, almost at the level of when Denmark is playing in the Euro Cup. Everyone watching the press release to understand what's happened the past week and what can they expect for the week coming up. So they had a really nice collaboration. I think probably one of the strongest collaborations, multidisciplinary collaborations in Europe. Spain was at the other end, and since I was constantly going back, it was interesting to experience that. You can, of course, tell us what was going on in the UK. Things got so difficult in the UK that I found myself called a couple of times to speak on the BBC and Sky News, something we did not learn, at medical school. And I said, why me? What's happening? They're like, yeah, everybody just complains about Boris Johnson. Everyone's so angry. Can you just tell us what's going on? I said, well, I don't know. I mean, I'm trying to understand what's going on in the UK, but I don't live there. So we had some very interesting discussions early on when they were trying to engage. The media was all over us. They wanted to understand the vaccine hesitancy numbers, broken down what it means in their country. They wanted to understand, what control measures should be taken and why they weren't be taken. And so this is just some examples. We were, in 250 newspapers in one day around the world. We started focusing in on long COVID, one of my greatest concerns now about the pandemic, and getting worse as we see repeat infections. We also talked personally about some of our motivations so we could show our side as, in a sense of reflexivity, my closest friend dying, my co-author Chris Kopka's father dying of COVID, and explaining that's not our motivation, but it also tells you that we understand the human suffering. This isn't just numbers. This isn't just something where we want to lock everyone up and make everyone wear face masks. There's reasons behind it, and we can discuss that if we want to in the Q&A. So I'll stop there. There's a lot of people to acknowledge from my team who worked to sort of set their PhDs aside, set their postdocs aside, and just worked on that big nature collaboration that took us over a year, as well as the 3 now vaccine hesitancy studies in 23 countries. I found it very surprising. You'd ask yourself, one of the biggest questions you would want to know is if there is a vaccine, are people going to take it? And I don't really understand why no one else was studying that. It's captured the attention of the media, it's captured the attention of our colleagues and in the peer-reviewed journals, but that study was really one of the easiest studies I ever did. I mean, we only asked 2 questions, right? Would you take the vaccine? And one, if your employer mandated the vaccine, basically would you keep your job? Later we expanded it and we created, a tool and an index and so on. But the first questions were really basic, but it shows how poorly the world was prepared for this pandemic when it took, bootstrapping academics to ask these questions to bring people together. We've handed it over in the I'll end now, but in the 0 draft of the pandemic treaty that you can find online, you'll see a surprising number of lines and phrases that come right out of our paper, which we're very pleased about. So the whole of society approach, the whole of government approach, the emphasis on addressing communication, including false information, and false information broken down into malinformation, disinformation, misinformation. So these are complex issues. People intentionally spreading false information, those doing it accidentally, and so on. So we tried to cover all of that. Communication isn't my field, so we brought in communication experts to help us. And I'll just end by saying, yeah, it was a large multidisciplinary effort that sets out what a large group of technical experts think need to be done to end this as a public health threat, but also shows the disagreement. And we can learn a lot in that disagreement because many of the people involved in this study were leading the response in their country. So I won't mention which country, but for the expert who said it's not air transmitted through the air, they're not taking the precautions they need, even though we have strong evidence about how the virus is being transmitted. So, thank you.
Thank you, Jeff. We now heard that the number 1 recommendation is the societal preparedness. And you mentioned already communication is the second most important thing to do, which is why we have Kristina here today.
Thank you. Thanks for having me here. And yeah, I think as we've got a bit more time, I'll just sort of talk about how I got into what I do today as a behavioural scientist. And it was actually organising an event, being an event organiser. So I did my degree in psychology, didn't quite know what I wanted to specialise in, and it wasn't clinical psychology, so I had a few years out working. And I was organising an event for the World Health Organisation and the Department of Health, who were coming to London to talk about non-communicable diseases, which I'd never really heard of back then. And I just couldn't believe that these diseases were preventable by human behaviour. And so this got me really interested in, what is it that drives our behaviours? And so I returned to my studies 4 years later, after working in actual digital marketing as well, and studied health psychology and became really interested in health behaviour change. And I then did my PhD at Warwick University, which was combining my industry experience of digital technology with my academic knowledge of health psychology. So I specialise in digital health, but today I'm going to talk more about communication. And this is just really one policy channel which we can deliver our interventions within the real world. And really, health psychology, as a discipline, has moved away from these kind of traditional behaviour change models that really focuses on our conscious decision-making and our cognitions. And we've broadened out to models now that take into account our environment that heavily influences our behaviours and also our automatic influences on our behaviours. So our automatic thinking, our impulses, our drives, our emotions. And a lot of the work I'd been doing was about, educating, certainly in public health. If we educate people, if we tell them what not to do, then that's enough. But education alone is not enough to change people's behaviour. It's the starting point, I agree, we need to have that in awareness, but we also need to support and guide people to change their behaviours as well. And I draw on a health psychologist, Professor Teresa Martineau from Cambridge University, who talks about really that changing minds isn't scalable, and also it increases inequalities as well. So when we're talking about health communication, and as I said, this is one sort of policy option. So thinking back to kind of the COVID times and wearing a mask, for example, there are lots of influences on wearing a mask. One might be a motivational aspect, and this really links to, I forgot I had some slides actually, I got so into talking to you all. Okay there. And this relates to a model known as the COMBI model, which is the Capability, Opportunity and Motivational model. And this model proposes that for any behavior to occur, we need to have 3 interacting conditions. We need to have this sufficient capability, which, as I said, is that educational part, that knowledge and skills. But we also need to have sufficient motivation, and that can be divided into our reflective motivation, so our beliefs about things, and also our automatic motivation, our impulses, our drives. And the third condition is we need to have that opportunity to carry out the behavior. And this is afforded by the people we have in our environment that either hinder or encourage the behavior, but also the environmental context, the time we have, the resources we have, the finances we have. So all of these things need to be in place for more complex behaviors to occur. So when it comes to communications, they're really good for targeting our psychological capability. They can educate us on what we need to do. They can also help to persuade us. So that's another intervention, a broad intervention strategy that we use that links onto our reflective motivations. So you can see here, this is a popular intervention development framework, which doesn't have to be used necessarily just for health behaviors. So it's for any behavior change intervention. So you can see that at the center of this framework is the behavior itself. And then the outer layers moves on to the influences that drives our behavior, and the framework then helps guide you to the likely kind of broad intervention strategies that can change the behaviors. So things like education, modeling, persuasion. And these then link further on to the actual policy category. So these are the actual channels that deliver these interventions in the real world. So going back to kind of communications and thinking about a case study of wearing a mask, for example, it may be that someone's reflective motivation is about their identity, as someone that wants to protect other people, and that's a strong driving force for them wearing a mask, for example. So communications here will be around, resonating with that identity, and for people that don't have that identity, helping to shift people's identity, which isn't easy, and it's not easy to write these communications. Although I have been using ChatGPT for this recently, and it's doing an amazing job of this, but that's another story. But that's only just targeting one influence on this behavior of wearing a mask. What about something in terms of their capability? What if it's simply forgetting to wear a mask, when you're supposed to? So that's more about having something in the environment that we call environmental structuring, adding a prompt or a cue, a poster, wear a mask in this situation. But what about opportunity? What about the people around us? So I'm not sure what it's like here, but certainly in the UK, really, we had lots of communications about wearing a mask. Really, we didn't see an increase until it was made compulsory to wear a mask. Then that's when people started wearing a mask. So when other people around us we see, wearing masks, this has a huge influence on us, and when it's made compulsory. So I think what I'm trying to get at here is that communications have a place, and they have a lot of impact, and certainly for maybe one-off behaviors. But when it becomes maybe more complex behaviors as well, we need more than just one policy channel. We need regulation, we need guidelines, we need communications, but we need them to be working all together to make a real change. So think about smoking. I've thought a lot about smoking since I've come to Vienna, actually, because I've seen a lot of people smoking. I can't leave the hotel without smelling of smoke because I go through a massive puff of it. And in England now, smoking is it's not so commonplace anymore, since we banned it in public places a while ago. But it took decades to get to this point. It started off with kind of having those individual services, stop smoking services, lots of health communication. Still, we didn't see anything. Then we had the images on the back, the fear appeals that we had on the cigarette packets. That didn't really help. Because again, that's trying to change the mind, don't forget. We need more than that. We need to change also people's behavior by making it difficult to do something. So taking away the opportunity to have a cigarette in a bar, in a pub, that brought people out onto the streets, and suddenly this glamorous, appeal, I guess, before of someone smoking became a bit not so glamorous, cuddled out in the cold. So the social norms of smoking started to change. It wasn't this fashionable thing anymore. And now we've seen a huge reduction. And really, unless we have something like this with this kind of effort on the obesity epidemic, we're really never gonna get there. If we just think it's a matter of health communications and being able to put a poster up about eating more fruit and vegetables, we're not gonna see any dramatic recovery from that, unfortunately. So a few things to kind of think about there. So I'll stop there, but I'd love some questions from all of you as well. So thank you.
Thank you. Thank you, Kristina. And you just mentioned questions, so that would be my next point. We are now in the question and answer session, and let's try to get some open discussion until time runs out. I don't think we have much time left, but we should be having some.
Yeah, 20 minutes.
Okay, perfect. Please, go ahead.
First of all, thank you for this really interesting talk. I'm Leon Brink, MICE 2 student from the Diplomatic Academy. So you had the example of smoking and making it unglamorous by kind of forcing the people out. But on the other side, what I read was also forbidding something can have actually the opposite effect of making it like cool and something people want to do again. Could you maybe elaborate on that, if you could find like the opposing effect in the end to forbidding something or restricting something?
Yeah. That's a really good question. I mean, that wasn't, I think, the aim of regulating it so that people couldn't smoke in public spaces, was just to make it much more difficult so that people might not do it as often, sort of thing. But a positive spillover effect, which we often have with these kind of behaviours, was that it started to actually change the social norms of what was thought of as glamorous, I guess. But there are other examples where I can't think of any now, but there are other public health interventions that have tried to kind of stop one behaviour, and unfortunately it's had a negative spillover effect to something else, like making it more cool to do and things like that. I mean, we've probably seen it now. We have less young people starting smoking, but we have vapes. Vapes have become cool. So that's an unfortunate negative spillover effect of public health kind of getting behind vapes, thinking that was better than smoking, but not realising that young people would now pick this up and it'd be the main sort of risk behaviour now that we see.
Any other questions? Yeah, please.
Well, I'll go here and then there.
Okay, yeah, perfect.
Right.
Dr. Lazarus, thank you both for presentations. I guess before we had COVID, that some governments had plans. I think the Bush administration in America had a plan. Obama administration had a plan for the next big thing after SARS, but obviously nothing was done. Why do you think that what you've done with this Delphi model and identifying all these recommendations, why do you think that it's going to get implemented, and what are you doing to make sure that it does get implemented? Thanks.
Yeah, I mean, WHO, where I worked, has the international health regulations from 2005. So all countries were in contact, and they were also in contact in December and January about what was going on in Wuhan. Why it doesn't translate into adequate action, it depends on the particular context, but I think definitely the economy or economic concerns was driving that. Also, it was politically unpopular to put any kind of limitations on any kind of freedoms for people. So countries to different degrees hedged and waited it out. But there hasn't been a lack of plans and a lack of communication about this. It hasn't always been very transparent, and it certainly hasn't been introduced and implemented. Otherwise, we wouldn't be where we are now. Spain knew exactly what was going on in Italy, in Lombardia, when thousands of people were dying, in February and March 2020. Spain, the rest of the world, but certainly the Spanish authorities were in daily contact with their counterparts and chose not to take the needed action. I think also for a lot of people, it was just hard to believe this would ever happen. They weren't alive in 1918. Maybe they didn't read about the last big, flu epidemic. In 2009, we shut down H1N1 pretty fast, or it just didn't really even take off. But in Asian countries, there were countries that chose elimination. So both Australia, but a number of Asian countries, we saw mask wearing is much more common. It really wasn't that big a deal for people to wear masks. They were wearing them for different reasons, largely due to outdoor, air pollution, and this was really an indoor epidemic. It was easier. So countries chose elimination, or they chose mitigation. And we did an economic analysis led by Miguel Oliu-Barton, a mathematical modeler, a mathematician who had never written for a health journal before. And he contacted me and said, we should analyze this and we should publish it in The Lancet. And I said, well, it's not so easy, to do. But we did it, and he showed that GDP recovered more quickly in countries that chose elimination. Lockdowns were shorter, and mortality and human, let's say, health burden was much lower. And that was at a time when countries could still change, and again, they were choosing not to change. And I remember I was organizing a conference in London, and we hadn't canceled the conference because on our side it was, well, we'll lose all our money. And on their side, they said, well, we're not going to give you the money back because we have a contract with you. And it wasn't until the pandemic was really declared that insurance companies kicked in. There was a lot of special interests and a lot of political and economic interests in that. Now, why do I think ours is going to get implemented? I don't necessarily think it's going to get implemented, but I'm a scientist. We did a scientific method. We came out with recommendations that were evidence-based already, but we showed the order and why they're important. And what are we doing? Well, I'm here today. On Monday, I was at the Pasteur Institute. On Tuesday, I'm back in Paris. On Friday, I'm in Dubai. We're a large group of people presenting, pushing. We've seen things taken up now in the zero draft of the WHO treaty, but we've also seen that just like with IHR, the International Health Regulations, there's no real accountability mechanism. If you don't do what's recommended, nothing really happens to you. This is very different than the ICC, the WTO, other international organisms that, not many, but that actually can override national sovereignty. And that's why I think this is really a political science issue more than a health issue. If you look at the treaty, the draft of the treaty, it starts with recognizing and reaffirming the sovereignty of every country. But maybe we need to start rethinking these sovereignty issues if that means a variant of concern can develop in your country because you're not mitigating the virus that then spreads and shuts down the world. So I think we're probably right now on a path to have more of the same if the current virus mutates or a new virus emerges.
Tayo Salvador, my question was already partly posed in the answer to it, but I indeed wanted to ask if you could say anything about the political reception of the article you published, what your sort of feedback is on that, and also a bit in relation to that it was evidently published only a couple of months back in many countries, a bit towards the end of the, at least the COVID pandemic. So how does it relate to that? Is there a lesser reception and so forth?
Yeah, well, we were immediately called by the government of Scotland and asked if we could present it to all of the experts in the government agencies, which we did. We were called by the Dominican Republic. We'll present there. Various countries and nations have contacted us. Some of our co-authors are in high-level positions and have been able to share it there. We've been presenting it at conferences, large ID conferences across Asia, across the US. But yeah, I haven't really sort of mapped out country by country. I think at this point, probably all political leaders involved have heard of it because it was in Nature and it was such a large number of co-authors. But does that translate to uptake? Not necessarily. And I think you said yourself, at the end of 2022, not only things were starting to look a little better, but many countries just wanted to turn the page on the pandemic. And I mean, I'd remind them that, well, one in three of our speakers, it's a very small N, but 33% of the panel here has COVID. I went to dinner last night with my one friend in Vienna, and she had just recovered from COVID. Again, pretty small numbers, but we know people are still getting infected. We know there's still the effect of the presence of long COVID. The numbers that are coming out in the US are really frightening of 25, 30 million people with long COVID, the effect it's having on the economy. So I mean, I'd encourage politicians to think what more we can do. On the 8th of February, I was on the radio in Spain when they announced that day that we would no longer be required to wear face masks in public transportation, in buses and trains. And I was asked if I thought that was a good idea. And I said, no one's really been complaining about it. And we know that face masks work. They're not perfect, but we know they work. And we know that in public transportation, it's going to be extremely important with that mix of people on a bus, on the metro, and the train. And it's also about protecting the vulnerable. It's also about solidarity. It's also about anyone being able to take public transportation who has a condition that makes them more vulnerable, either because they're elderly or they have a comorbidity like diabetes or a respiratory disease. So I think it was a terrible decision. We've also seen the high prevalence of RSV, the high prevalence of influenza. So in the middle of all of that, the government says, hooray, we haven't seen that many cases, we can remove masks. I mean, this is not evidence-based policy making, yet it's policy making, right? People say, great, what a great decision the government took.
So just briefly, there's a few questions. So there's one here, then I'll see you in the middle, and then I'll go that way, if that's okay. If that works for the panel as well.
Yeah.
Hello, my name is Mariam Cindy. I'm a student at the DA. My question is for Mr. Lazarus. You mentioned the whole of society approach. What kind of support do local communities and groups like faith-based institutions need from international organizations to tackle vaccine inequities?
Thanks for the question. So, we know that there's been, in some countries, in some settings, low levels of trust, and in some settings, declining levels of trust as authorities have made mistakes in their pandemic response or stayed the course, and we haven't seen it working as well as people had expected. So the closer we can get to the community through trusted community leaders, both in the medical professionals, family doctors, but also faith-based leaders, the better it is. So the kind of support they need is to understand, what's true, right? What's misinformation and what's actually evidence-based information. So they need support in messaging, support in being able to provide those messages in the language, not just the translation of it, but in the layman's language that makes sense to that population. Like we said, the vaccines work against the virus, but they don't necessarily prevent viral transmission. They reduce, the severity of the symptoms. So it's been complicated with the language, and it's complicated for lay people to understand. So I think faith-based organizations need to be better listened to. They need to be a part of the conversation. And we need to do things, I think, like this study, and if you do it, it'll probably be without me. I'm not looking for another 192 articles. But I think every country really should have these kinds of multidisciplinary committees and hearings where they listen to the voice of the community. Several of the people in the panel, were strong representatives of community organizations arguing that really it's only going to happen if the community is leading the way. They may be right, but I mean, we need that kind of bottom-up approach from the community, but we also need, facilitators and a top-down approach. I mean, does Austria have a detailed strategy and action plan to address COVID-19? Does anybody know?
Yeah.
Like, why would one of the richest countries in the world with all of these amazing researchers and knowledge not, and I'm saying this because basically no one else does either, so I'm not picking on Austria. Like, why would you not have a multidisciplinary, detailed strategy and action plan saying, okay, if a variant of concern is discovered in Botswana next week, well, what happens here? Do we all wear our masks again? Do we close school for a week? Does the public understand the importance of ventilation and how we can do that? Do we have plans to improve air filtration in the long run when we're developing new buildings, when we're re-engineering schools and hospitals. So I mean, the lack of planning and the lack of strategy, I mean, you don't need to agree with anything else I've said here, or the panel at all, but it's kind of amazing, right, that in the middle of this pandemic, our political leaders haven't developed these plans. WHO also doesn't have a plan. And in March last year, when they put forward kind of a strategy, they don't even mention once the word airborne or aerosol. They don't even talk about how the virus is spread. And if we're going to address it, we need to know how it's spread. So the response is so incredibly deficient that you don't really need a PhD or to be a scientist to just say, well, why aren't they taking this seriously?
I have a follow-up question for Dr. Curtis, because you briefly touched upon the obesity epidemic. And for me, it's kind of difficult to get my head around how you would actually fight that, like with communication, to change someone to not eat the burger anymore, because it's sometimes the cheaper option in many countries, especially right now with all the economic struggles going on. And also you can't like really ban like a McDonald's as easily as to get like cigarettes or something. So maybe if you could share a bit on that.
Yeah. Well, I started as I said, my PhD was in childhood obesity, but it was it was a mobile health intervention. And so I really had to kind of understand, what the influences were. Obviously, you've got the energy side of the balance equation, and the energy out. So I was focusing more on the high density sort of consumption. And from my research, parents were obviously very important actors within this. So this was the target for our intervention. And so within the app, there had to be some communications or persuasive messages kind of thing, but it was linked to really helping them reduce their portion sizes, because first of all, they didn't know what an appropriate portion size was. So I did many focus groups with parents at children's centres. And actually, there wasn't any policy and regulation and government guidelines on what appropriate age portion sizes were. So we can imagine why it's been actually really difficult for parents. So that was the kind of educational part. So that's where communications can come in with. We used what the actual US Disease Center for Control uses, which is hand-sized portions, hands to kind of convey the image that for parents, you use parents' hands, they have bigger stomachs. For children, children's hands. Just to get that across, that we should be having different portion sizes. Adults should have different portion sizes to children, because this is not what we were finding in our research. So that could be one kind of communication around that. But I know a communication around that and an app itself on helping parents to kind of reduce their portion sizes at the point of food, serving food, isn't going to be enough alone. So what I'm saying is it would have to be more work done by the government. Yes, we've got a tax levy now on sugary drinks, but that's not enough. I go into my supermarket, and the other day I noticed they'd introduced another whole row of confectionery food. Why do we need so much confectionery food? And why is there not more legislation about the amount of takeaways, fast food restaurants that we have around schools within easy reach? So that's where I'm saying communications is one aspect, and that will help change some minds. But really, unless we change the infrastructure in the food industry and the obesogenic environment, we will not be getting anywhere. So that was just that point.
All right, we're already quite advanced in time, and we've taken some minutes off the coffee break. So one question?
Just last question.
Perfect, yeah, great.
Okay. Hello, my name is Marcus. I'm a student of economics and an intern at the European Commission in Austria. Earlier today, a speaker described the global distribution of vaccines as a multilateral shame, saying that countries in the global south didn't get adequate amount. So my first question would be, is there now sufficient information, sufficient research to inform political leaders to prevent that the next time around that global health crisis occurs, that we have a more empathetic approach, and that there's more equality? And my second question would be, my follow-up question would be, how big also do you think would the impact, the net positive impact, have been if we had distributed these vaccines more equally? And my next question would be, I would be interested to hear your thoughts on how these models to change and effectively change behavior how they apply to environmental issues that relate to public health, such as, for example, pollution that is caused within communities. Thank you.
Well, thanks for the question. I'll give you time to think, Kristina. I mean, WHO and the Gavi Alliance, so the Global Alliance on Vaccines and Immunizations, and CEPI, an organization that was set up before the pandemic to address vaccines and now funded with several $1 billion, pivoted pretty fast and developed the COVAX facility. So they knew this needed to happen. We knew that manufacturing had to be ramped up, and people like Bill Gates were saying we should be building manufacturing plants even before we have the vaccines in place. So we knew what to do, but countries were hoarding, and they were wasting. And you can look at our paper in the BMJ Global Health on vaccine wastage, and millions of doses of vaccines were being destroyed. The whole PSM, procurement supply management system was just not working well. When we were finally giving vaccines to Malawi or Zambia, they were about to expire, and their absorptive capacity is much lower. They just couldn't receive them. Even in Spain, we couldn't initially receive the number of Pfizer doses that we had ordered because we just didn't have the refrigeration at minus 72 or whatever it was. So you can imagine how it was going to warm countries, poor countries. So, we knew that in advance, and yet we hoarded the vaccines. We had the battle between the UK and the EU, where the EU had a contract, but AstraZeneca vaccines were being produced in the UK, and the UK government wasn't allowing them to be exported. So these are all, again, these are not health issues. These are all political decisions. And you mentioned, what can we do to make countries more empathetic? I have no idea. I mean, I don't think we can legislate that. We need to legislate, some kind of division of resources. And in our paper, we talk about, increasing manufacturing capacities. Some people think they should be increased in low-income countries. I'm not necessarily sure I agree with that, but we need to increase the manufacturing capabilities, at least globally, and have agreements in place, like is sort of being discussed in the zero draft of the pandemic treaty. But again, countries don't, sovereign countries don't want to be forced, to share. We'd rather have vaccines being wasted in every CVS and Walgreens across America where people stopped getting vaccinated than to get those to the countries that need it. So I have a lot of sympathy to low-income countries saying, then give us the capacity. But it's very, very complicated to produce the mRNA vaccines, so it's going to take a while. But with the Gavi Alliance, who's working in, I think, over 60 countries, they have networks set up for distribution, and they weren't really being used because countries wouldn't allow the vaccines to leave their borders.
Yes, thank you. That's a really interesting question. So I think I've been using the sort of example of health, but this model of behaviour, the one that I mentioned, the COMBI model, as well as the framework, the behaviour change wheel, is applied to any behaviour, and that's what we're talking about. It's human behaviour, so whether that's a health behaviour or it's about environmental sustainability, it's about identifying what is the behaviour you want to change, and then who are the actors in that system. And then working out which level you're going to intervene at before you then think about what are the drivers behind that behaviour. So it can certainly be applied to other areas, not just health. But great question, thank you.
Thank you. Thank you for the audience, for your questions, and thank you for the speakers for being here. Thank you, Jeff. Thank you, Kristina. And I hope it was an interesting panel, at least for me it was. And the next panel will be taking place in 50 minutes. So until then, see you, have a nice day, and thank you for being here.
Thank you.
Thank you.